All right, guys. Well, welcome to episode 150 of the Crisis Jam. My name is Laura Evans. I'm the AVP of Public Policy and Government Affairs within Vibrant Emotional Health, and my pronouns are she and her. Today, we have a great featured presentation for you from Dr. Tia Dole, who's the Chief 988 Officer. So before we get to her presentation, let's go through and catch up with what's been going on. Of course, you can sign up and register for the jam on talk.crisisnow.com. Again, you'll see the weekly reminders, ways that you can get virtual backgrounds. You'll see some folks having, as well as see what did we talk about last week. You have a link to the entire presentation there on YouTube. But also, if you want to find out a certain segment, what was the particular hot seat topic, we have that broken out there as well. So again, keep talk.crisisnow.com bookmarked and you'll never miss a jam. So our top 5 jam episodes here. Number 1, youth episode with Dr. Anita Everett, Dr. Belina Shaw. Dr. Shaw will be coming back to us soon. 988 going live with Dr. Delphin Rittman. Crisis Receiving Centers Tech number 3. That was a really great episode. So you can watch all of these again on that YouTube channel, and there are other episodes. We'll see the next slide, the top 10. But I think all of the Crisis Jam episodes are great. So make sure you take a look at the YouTube link and see any topics that interest you. And again, some of these speakers will be coming back to give us updates. Speaking of speakers, there have been over 400 unique speakers across 150 episodes of the Crisis Jam. And so you can see if you, again, have an idea, if you want to share your perspective or your view on any portion of 988 implementation or crisis services, please let us know and we can make sure to get you featured. Again, there's the email in the chat. And if we go to the next slide, you'll see, again, just some of the speakers who have been on the jam. So there's a lot of names there. And of course, we want to add yours. Right, next slide. All right, so you all may have heard in the news around Meta and the social platforms and their impact on youth mental health. So I'm going to bring in Sophie Shev, I'm sorry, to speak to this topic. Sophie?
Hi, everyone. Happy 150th episode. Thank you so much for having me on the show. I wanted to just speak a little bit about this super important update that's been around the news. I'm not sure how many of you have interacted with this yet, but essentially 41 states and DC and 33 attorneys general have filed federal lawsuits against Meta, claiming that its social media platforms, Instagram and Facebook, have features that are inherently addictive and are targeting teens and young kids. You know, a lot of people have some mixed feelings about whether this is fair or not. But in my view, as a young person who has been affected by the social media mental health crisis and kind of sees my peers go through this every day, I think this is a super important step on taking the onus off young people and their families and putting it back where it should be, which is on these platforms, which are knowingly and negligently harming young people and having a negative impact on their mental health. I worked on a California bill, SB 680, which was essentially meant to do this on a state level. So it's really exciting to kind of see this pick up some federal momentum and really looking at how the federal government can act to hold these social media platforms accountable, essentially put in the safety features and seatbelts that we have in cars that prevent so many young people from dying every day, that are now standard safety features, which once may have been seen as controversial. That's what we're trying to do with social media here. And as a youth advocate that has kind of been on the front lines of this, it's very exciting to see the older generation kind of picking up on our advocacy, picking up on our momentum, and also ensuring that we are not the ones that are being blamed. You know, it's not just kids these days are spending too much time on their phones. It's kids these days are spending too much time on their phones because the companies that are creating the social media that are on them know that if they spend more time on it, then they will make more money, essentially turning young people's vulnerability to addiction and mental health disorders into capital for them. So I'm glad to see some resistance against that. And this is, yeah, just some exciting news. I think it's very important for everyone to be aware about, providers, stakeholders, policymakers, parents. Yeah, there will be a lot more to come soon, you know, as these like lawsuits kind of come to fruition, as you know, they potentially make it through the court system, and as we see new laws develop.
Well, thank you so much, Sophie. This is really interesting. And we'll be sure to bring you back to just make sure that we're keeping up on what has happened. So let's go to the next slide, please. And just some other items in the news. This USA Today article, again, you'll see linked in the chat. My mom's suicide wasn't a personal failure. When she needed community, the system let her down. And again, what we're all working towards to prevent and ensure that no one slips through the cracks. Next slide. So if you are interested in helping to ensure that more folks are aware of 988, please utilize the link, and I believe we have that in the chat as well, to the SAMHSA store. You can get 326 items for free that are branded 988. Again, Spanish options and other stickers, magnets, posters, etc. So be sure to reach out, and I believe the shipping is up to date. I know some folks had some issues with the backlog, but I hear things are getting out, so make sure you put your order in. Next slide. Okay, and speaking of options, you have the option to have a jam session t-shirt. We have short sleeve, long sleeves, hats, 5 different quotes to choose from, 4 different logos, various color options there. So as folks are experiencing an Arctic freeze, you can go from short sleeve to your long sleeve shirt. Again, available for purchase at the link in the chat, but you can also get one for free by participating in the hot seat. So if we go to the next slide, our crisis trivia hot seat participant today is Bart Oates, who is the executive director of CIT International. Bart, are you here? Can you come off mute and on camera?
I think I am off mute, and okay, my camera should be on.
Awesome. Thank you. I see you, Bart. If we will get you spotlighted in just a moment. And for folks not familiar, and we can go to the next slide, Crisis Hot Seat is our version of the Who Wants to Be a Millionaire. So you do have some options for lifelines. You can poll the audience, which we will do, and you can call on a friend to help walk you through this. And again, if you just want to walk us through your thought process. Today's trivia question is focused in on emergency systems. So you may already be familiar with this, but a 911 emergency system was a revolution in telecommunications. The concept of using a simple code to call for help on the phone took hold and spread across the globe. So the question this week is, the first ever call to a national 3-digit emergency system occurred in what year and in what country?
Okay.
Do you want to call anyone to join you?
Yes, I'd love to get Sabrina Taylor. I think she's on.
I am on. Shoot, I'm not sure that I know. I was going to say the UK, but 1937 seems awful early.
Leanne has noted in the chat, this question has been asked before, and she's very astute because this was a question on the Crisis Jam 2 years ago. So,
oh, you know, if my memory worked, I would remember. Can we see what the audience thinks?
Yeah.
Oh, they don't know either.
Pretty split. We've got D.
Well, yeah. Okay.
I mean, I guess I'm biased towards the US. Everything I've read publication-wise has been US specific.
All right, Bart, it's your call. What's your choice
here? Okay, I'm going to go Australia. B.
Final answer?
Final answer.
All right, the actual answer is D, the UK. So Sabrina, your first thought was correct.
Wow.
Man, I should go with the gut. Thank you.
Yeah. No problem. Look, you still get a t-shirt or a hat or long sleeve shirt, either way. But the as put in the chat, the UK system, the 999, is the world's oldest. And then on July 8th, Miss Beard of Hampstead, England, called 999 to report her husband was chasing a burglar around the neighborhood. According to press accounts, then her quick call led to police apprehending the subject. So very tough question. One from the vault.
Good question.
Yes, we have some folks who have great memories, Amy, Leanne. But again, thank you, Bart and Sabrina, for walking us through that.
Thank you.
Awesome. Well, let's go to the next slide. And I believe our quote today comes from Shelby Rowe, who many of us know from SPRC, which is housed within the University of Oklahoma Health Science Center. And this quote was in the context of states needing to include American Indians in their 988 plan. But I think this quote just fits for any situation when we're talking about working with individuals who may be experiencing an emergency. It's not making individuals in crisis fit into a system. It's adjusting the system to better meet the needs of those individuals that they are serving in crisis. So again, as we are all working to create a better continuum, something for us to keep in mind. Crises don't occur from 9 to 5 anytime. So with that, we're going to head to our feature presentation, where I am honored to have Dr. Tia Dole join us. She, again, is the Chief 988 Officer within Vibrant Emotional Health. And you all know Vibrant from our work as the administrators. Tia?
I'm ready to rock and roll. Okay. Hello, everybody. Tia Dole, she, her, hers. I am a clinical psychologist. And so before I jump into my presentation, I did want to share a little bit about my background for folks who don't know who I am. So I'm the Chief 988 Officer at Vibrant. I'm also the Vibrant, with the support of SAMHSA, we're the administrators of 988. And I thought, because I know some people on the call, that maybe I'll share something about myself, about how I got into the field of suicidology, which was in the 90s, which is then now telling you how old I am. I actually started working in the field of suicidology by collecting data at a community-based hospital in Georgia of women, Black women who had recently made a suicide attempt. And so I would sit in the ER and wait for people to show up or get paged. We had pagers back then. And I would interview women who had come in after a suicide attempt and talk to them about why and what could have been done. And I can say that that was probably a huge influence on my career, obviously, and humanizing folks who have made suicide attempts and why people think about suicide and what's happening in our society and our environment that push people to that. So, I've been doing this for, I guess, almost 30 years. So I'm really excited to be here. Thank you for inviting me. And, we can go to the next slide and then we can get into our presentation. Okay, this is our disclaimer. The things that I say aren't necessarily the opinion of Health and Human Services or SAMHSA. So next slide. Okay, so I hope everybody here knows, but 988, we are 24 hours. Listen, Melissa, I really do skip 2000 to 2010. I have missed it completely. So I feel you. So 988, we're 24 hours a day, 7 days a week. We have about 215 crisis centers, which I'll talk more about. We're funded by SAMHSA, and we are administered by Vibrant Emotional Health since its inception in 2005. One of the architects of this is, I think, on the call, John Draper. So thank you, John Draper. You did a fantastic job and creating something that is really incredible and a linchpin to our crisis continuum. So we have about 215 centers across 56 states and territories. People don't think about the territories, and you think about Puerto Rico. It's pretty amazing what folks have set up. So next slide. what you can see here, it got a little wonky on the end, but where it started, right? And so what you can see is that we incorporated the Veterans Crisis Line. We added chat and text chat services actually a decade ago. And so you think about where chat is now and versus today, versus before, it's actually a big deal. And then in 2020 is probably where we see the National Suicide Hotline Designation Act, which was that the FCC designated the number 988. And I can tell you that there was a lot of back-end haggling to get the 988. And then we launched last year in July of 2022 to have an easy to remember number, right? A 3-digit code. And then it expanded to include text. So, and then in the last few months, we've launched our LGBTQ subnetwork, which I'll talk more about. Next slide. Okay, so how 988 works. For some reason, I love this slide because it provides clarity about what we're doing. So someone dials 988, right? Or they use our chat platform, which is like Lifeline, 988lifeline.org. When you come in, you can either decide to press 1 if you're a veteran, 2 if you need services in Spanish, or 3 if you're LGBTQ plus youth. In the state of Washington, you can press 4 if you identify as Native American. And today I'm going to talk a little bit about our subnetworks and what's behind thinking for that. But then you are routed by the IVR is what we call, right? These press numbers. But if you're not interested in those specified services, then you just, generally speaking, go into the local call centers. And what that is we want people to go directly to what is closest to them. And we route people based on area code for now. What that means is I live in the New York area. If you have a 212, you get routed to the call center in New York City. And then if the wait time is too long, then you get routed to the backup call center. And one of the things that we are working on always is answering calls as quickly as possible and ensuring that the local networks have first shot at answering those calls, because the local networks are the ones who know all the things. They know what is the hospital that folks could go to. They know about local resources, and it's really important that people are being helped by their neighbors. And so that's something that we spend a lot of energy doing, is making sure our local networks are really up and rolling. Okay, next slide. Okay, so I think we've gained about 10 call centers in the last year. We have 15 national backup centers. And then one of the things is that we've served about 6.5 million people since July of 2020. Just so you know, and John Draper, you have to keep me honest, I feel like in the first year we served like 45,000 people. And so to think about that I would consider that exponential growth since July 2020, 6.5 million contacts. And people ask me all the time, do you have familiar voices? We absolutely do. Every call center does. But we consider each call as an individual. And wait times have been reduced from 2 minutes and 39 seconds, excuse me, to 41 seconds. And one of the things I want to say is that where we want to go is below 30. And the reason for that is that if you look at our data, you can see the abandonment rates really start to drop right at 30 seconds, meaning people drop off the call. It was 40,000. Okay, great. And what we have also seen is that there was a 46% increase in calls, 141% increase in chats. And then you look at this text. That's not a typo. That's 1,135% increase in text. Where we see about text especially is, you probably guessed it, it's young people who tend to reach us out to us on text. You know, they don't like to talk on the phone. My kids don't either. Okay, next slide. Okay, so, you know, it's an interesting thing. People ask me all the time, like, well, why aren't there more subnetworks? What is a subnetwork? A subnetwork is something that is typically more than one center. What that means is that SAMHSA has designated a special population. So for instance, LGBTQ. Congress passed some legislation that says, okay, we're going to fund this, and we're going to actually create a subnetwork for LGBTQ. And so we piloted with the Trevor Project where I used to work. And actually I was the one who negotiated on the other end. So it was a funny thing to be on this side. And then once the pilot was over, it was like, okay, this is very clear that this is a needed service. And then since then, we now have a subnetwork for LGBTQ youth of 7 centers. And it's important to note that, from my perspective, it's an interesting thing to think about who is a special population and who gets designated as such. But the way that it works is usually we do an RFP process. And so folks are able to apply and say, listen, we have counselors who are prepared to serve folks. And then FTEs are designated based on estimated volume. Now, a few things which I like people to know is that we don't typically collect real demographic data. We have a pre-chat form that people, when they chat and text, they can fill out. But when you're in the middle of a crisis call, a phone call, you're not asking people about their ethnic identity, for instance, unless it's part of their presenting problem. And so estimating volume is actually a big deal. And Ryan Casper is going to come on shortly, can talk potentially, if that's part of his talk, he could talk about that. But thinking about like how many people actually need this service is probably the most tricky part about establishing a subnetwork. Next slide, please. See, Howard, I see that the power of peer support. Yes, that's 100%. And I think it might come up soon. Okay, I have a typo in here just so you all know. So we have 11 voice backup networks. So we consider that a subnetwork, right? And then we have 20 chat. We have 7 centers doing LGBTQI, and then we have 6 centers doing Spanish. Now, this is interesting doing Spanish in another language because you have to think about the platform that we're using. You have to think about making sure that we have trainings that aren't necessarily just translated into Spanish. They're actually created in Spanish because when you translate things, you lose context. And then most recently, we actually have 2 centers for deaf and hard of hearing. And we launched our video phone in September. That's incredibly exciting because we're offering folks who are deaf and hard of hearing services in potentially their first language. Now, I'll tell you that my internal policy person, Shai, told me that she was like, I want people to know that sometimes someone who is deaf and hard of hearing, their first language is ASL, but people who lose their hearing later in life often don't pick it up. So chat and text is also available to them, obviously. And then, of course, we have native and strong. There's 1 center, that's a typo, versus 2. And that was set up through Washington State. It's a really incredibly powerful service from my perspective. The volume is 500 a month, but I think it's really important to think about the Native American population in this country. So that's why I had another slide. Next slide, please. So I use this as an example of just one service. And what you can see here is, let's say in September, and I hope it's not too small, we had about 400 people use the service, right? Routed to the service, and their answer rate is at 82.7%. I will say very clearly that we always want answer rates to be above 90%. That's always the goal, but this is 1 center, right? And so they're doing their best, and Ryan works with them very closely in order to ensure. And then we can see how many people abandoned right here. We had, I'm going to say guesstimate like that's 60 people. And so the average speed to answer is 29 seconds. And so you have to think about like, why are people abandoning? Are people testing out the service and things like that? So those are the conversations that we have with centers. And ultimately speaking, our technical assistance is interesting because we want to make sure that centers are staffed correctly. We want to make sure that they're picking up calls. We want to make sure that they're doing QI. And so our role as administrator is pretty intense. And I suspect centers do get sick of us. So that's something that we are well aware of. But we're just really excited about all the work that the centers have done, because they are really ultimately speaking the heart and soul. Like they're the beating heart of this network. And if you really think about it, 988 is the only service in this country that is offered free, right? that is anonymous, and that is available to anybody. There is nothing, right? 911 is 5,000 call centers across the country that don't talk to each other. 988 is a network. It's an ecosystem that we've created thanks to SAMHSA and HHS, and the Biden-Harris administration has invested a ton of money into making sure that this is an incredible service. And so I'm really proud of the work that's been put in by folks across the network and by the crisis centers. So there's a lot of coordination in there. Okay, next slide, please. Wait, this is probably less exciting. So one of the things is, and maybe we'll talk about this later, but ultimately speaking, you know, we've launched things like a core clinical curriculum, making sure that everybody has like a universal set. And what that means is that crisis centers all have their own internal training. Most crisis centers have between 35 and 40 hours of training for their crisis counselors. But over time, they can't keep creating trainings. And so our job is to push out trainings, LGBTQ trainings. Let's say if you want to work with suicidal people of color, or you know, things that are happening in real time. Sometimes we do webinars and sometimes we do asynchronous trainings. And our most recent like kind of big training was our Spanish training, Spanish language training. So that's a big thing that we do, curriculum. The other thing is that we've created something called the Unified Platform. It's essentially a CRM based on Salesforce that is made for crisis centers. So if you know anything about crisis center, most crisis centers have what I would consider to be a Frankenstein CRM to pick up calls. And oftentimes you have like a bunch of fields that prevent you from saving the case record, all these things. And so we've created one that's free of charge for crisis centers to be able to answer calls, chats, and text. And it's actually really incredible because SAMHSA really made it a huge priority, and it was a big undertaking that came out really quickly. Next slide. Okay, so that's some of the things that we're working on. One of the things that we are doing this fiscal year, federal fiscal year starts October 1. September 30th, a national awareness campaign. So if you think about the volume that we've had 6.5 million people reach out to us since 988 launched in July, that's basically through no real campaigns. My hope is that you all have noticed lately on highways, in parking lots, the 988 number. We want to embed in schools, and sort of like, just like when I was growing up, it was like stop, drop, and roll, right? That the numbers 988 become embedded in the consciousness of folks who live in this country, so that they know if they're having an emotional crisis, they can reach out to us. And then ultimately speaking, we have a guesstimate of 6 million people in 2024. I suspect that we'll surpass that, and 7.5 million in 2025. And one of the biggest things is actually like call center capacity, and making sure that the local centers are answering calls. And so and then we do a little bit of work around the crisis continuum with law enforcement, with crisis, mobile crisis teams. But I try to make sure that we stay in our lane. We are a stop along the crisis continuum. We are not the crisis continuum. So it's really important to me that we offer support where we can, and that we are the connector, but we're not all everything. And so the question that everybody asks me is, you know, is 988 going to end suicide? Now, I am a strong believer that we can end suicide in this country. That's my sort of goal. And during the course of my career, hopefully it'll happen sometime before I retire. But I do think that 988 is just such a unique opportunity to help people in a way that has never been done before. And so, you know, I just experience a lot of pride to be part of the team. And if you have any extra questions, I'm going to drop my email in the chat. You can email me. And I think I'm done. I just got to think. So Dole, thank you.
Awesome. Thank you, Tia. Really great information. And I'm going to bring in another colleague, Ryan Casper, who's the AVP of Network Operations for the 988 Suicide and Crisis Lifeline within Vibrant, to share his perspective. Ryan.
Yeah. Hi, Laura. Thank you. Hello, everyone. My name is Ryan Casper. I am the Associate Vice President of Network Operations for Vibrant Emotional Health. My pronouns are he, him. I have, just to introduce myself, I have almost 15 years experience in developing and managing service networks across the United States. I've got a long run in contact center operations and government contract oversight. I am super grateful to be in this space. I love crisis response and the 988 system. My personal mission is that I'm driven to improve access and reduce barriers to critical care for help seekers, how, when, and where they want it and need it. So here today, I wanted to reflect Tia's presentation. It's scratching the surface of what we're doing and what is yet to come. And Tia spoke on our efforts and goals to develop capacity within the network as all services grow. And it's very clear that the 988 Lifeline is growing at a significant pace. Starting from 45,000 interactions to 5.5 million to 7.5 and then beyond, right? So in order for this ecosystem to thrive, we have to be focused on ensuring that we are educating, developing, and supporting centers in a space where historically capacity planning and workforce management has never been a capability of crisis centers, and that's really mostly due to funding and scarcity in resources. And so now as we enter into this next phase of the Lifeline's history, we have new opportunity and capability for the 215 plus centers within the Lifeline to start to be focused on those ideas and concepts. In last year, in October, Vibrant launched its 988 Workforce Management Division to help centers understand, develop, and leverage workforce capacity and planning. And since then, we've met with over 150 centers in the Lifeline to help them understand data surrounding workforce management, forecast out their FTE requirements, and then look at growth. About 70% of centers who meet with Vibrant and our workforce management team carry on the data and the analyst relationship because they see that it can be helpful for them. And we typically see about an 8% increase in performance for every center that does that work. That's really phenomenal. It's all about the centers leveraging the data and really getting something out of it. So capacity and planning just overall is very important to the success of these subnetworks and then also generally the Lifeline. I think, Tia, one thing I wanted to highlight here as I was reflecting on your presentation is that not only did we launch 3 service networks this year, but there were major successes around those service launches. The Spanish chat and text, for example, historically, a launch can always be a bit I'm going to butcher the word tumultuous, and it can also be one where we don't really know against our best forecasting how much volume is going to come, right? So we talked about how do we forecast for that? How do we research what we think the service is going to look like, and then how do we land with enough capacity at launch to make certain we can answer the call? And our Spanish chat and text service has launched and maintained 100% answer rate over the last, 3.5, almost 4 months now. Our video services launched in September, and we have a 97% answer rate there. And so the important impact here is that adoption of the service is going to be dependent on the success and the viability of the service. And if we don't have counselors that are able to provide those familiar voices at the time when they are most needed, and especially as you launch a new service and people are testing out what it is, it could be very challenging to maintain that growth.
Ryan, we've got a couple of questions in the chat,
Yeah.
and so I'm wondering if you or Dr. Dole would be willing to speak to them. The first being, how long does a person wait at a local center before it's rerouted to another center or the backup network?
Mm-hmm. Yeah, so I can handle that question, Tia. We have variable configurations within our ecosystems. So it's configured by center. Sometimes it is as short as 30 seconds. Sometimes it is more than 2 minutes. But we use data and also the technology within each center to determine what that is going to be. What we are most concerned with is ensuring that there is an appropriate a wait time to ensure local response first. We want states and local centers to have opportunity to answer the call, and then we will move it to a national backup system.
Awesome. And another question that came in, and again, recognizing that no community is a monolith, for Spanish, is that a formal or informal Spanish? Do we know?
Well, I think it's going for the centers that we have. I will say that we provide the space for the counselors to provide that level of communication. Our unified platform is translated in Spanish, but it also allows for either monolingual or bilingual individuals. And whether or not they use a formal or informal Spanish, I think is directly up to the counselor.
Awesome. And if someone wants to speak in a language that's not English or Spanish, are there options?
I can answer that one too. While we don't have other language-based specialized services, we do have translation services. So we have language line and language interpreter services for any individual that contacts the Lifeline. And we do get information about the usage and utilization of that service, which does help us to inform whether or not we should be building language-based services in the future.
And just a couple more questions here. Thinking about that entire continuum, as Dr. Dole referenced, and Lifeline being one part of that stool, is there any data that you're aware of for involuntary hospitalizations after connecting with 988? Or perhaps this, maybe they're asking for us to speak to the suicide safety policy. And we probably have about a minute, so if you want, we can put that one in the chat, just because I know there are other exciting segments we need to get to in this jam. And I know there's already some conversations going on in additional questions. So again, keep those questions coming. We'll try to get to those in the chat. But again, thank you, Dr. Dole. Thank you, Ryan, for this great featured presentation. I know it was very informative, certainly for me. All right, let's go to the next slide, please. And I'm going to turn it over to our Crisis Jam kind of favorite known entity, Tiffany Russell. Can you give us a SAMHSA update?
Thanks, Laura. Hi, everyone. I'm Tiffany Russell. I am the Chief of Crisis and Justice Initiatives here with SAMHSA's 988 and Behavioral Health Crisis Coordinating Office. And I'm super excited to be here for the 150th episode. I'm also super excited that I got to follow my colleagues over at Vibrant Emotional Health. Always good to see them and hear all of the great things that are happening with 988. Today, just wanting to share a little bit of information about my particular portfolio of crisis and justice initiatives and talk about some of the work that we have going on regarding 988 and 911 coordination. Really excited to announce that our Connecting to Serve, which is our 988-911 coordination webinar series, has begun. It was the first episode aired on October the 12th, with the topic being the foundation of 988 and 911 coordination, what states, territories, counties, and jurisdictions should know about 988 and 911 coordination. We had about 700 folks to register, over 400 to participate during the actual webinar series. We were super excited to have 3 really informative presentations to happen during that time. That particular webinar series is actually going to be a bi-monthly webinar series that will continue on 988 and 911 coordination. We're going to tackle all sorts of topics around risk management, communication between the states and 988 and 911 centers, and just really kind of tackle some of the topics that come up when folks are thinking about what does 988 and 911 coordination look like. So our next episode is actually going to take place on December the 14th. And you can go to our Crisis Response Technical Assistance Center website to register for the upcoming webinar series episodes, as well as see the recordings of the previous webinar series episodes. And so our very first episode is already there, and you can watch it if you missed it on October the 12th. And then again, you can also register for the upcoming session that is on December 14th. And I will drop that link in the chat for everyone. Additionally, to discuss some other things around 988 and 911 coordination, on this Friday here at SAMHSA, we are going to be hosting a very small convening with wireless carriers and 911 representatives to discuss some of the topics that come up around 911 and 988 coordination related to exigent circumstances. And so when one of our 988 crisis counselors determines that someone is at imminent risk, or has determined that someone is at imminent risk, these are the times that we typically transfer those calls over to 911 call centers for some type of emergency dispatch or welfare check. And so what happens during that process is something that we wanted to discuss with wireless carriers, because we wanted to make this process the most efficient, streamlined process as it could possibly be, because we know that this is a time when that person that has called into our 988 centers are at the most risk and they're the most vulnerable. And so we want to make this process as efficient, as streamlined as possible for not only our 988 network centers, but also for 911 and for the wireless carriers that are involved in those calls. And so we're having a small convening with them on this Friday here at our SAMHSA office to discuss what can we do to make that process more streamlined. Are there some trainings? Are there things that we can iron out and discuss amongst ourselves that as we are making these call transfers to make them a lot more easier and more streamlined? And so we'll be discussing that on this Friday. And also just to continue talking about how we are assisting first responders. We are doing a lot of work with not only law enforcement around 988 and the crisis response system, but we also want to work with those first responders like EMS, our paramedics, our firefighters, because they are also involved in behavioral health crisis response as well. It's not just police and co-responders. And so we want to inform them of what 988 is, how it can be used in the community, but also how can they use 988 and those services for themselves. They are also at a very high risk in mental health crisis as well. And so, which is understandable with the type of positions that they have and the kind of work that they do day in and day out. And so we are hosting a convening at the end of the year with EMS, firefighters and paramedic associations to talk more about how we can support that community and inform them about 988 and the crisis response system. And so we're really looking forward to that convening with them. And hopefully we'll walk away with opportunities to share not only what our services are, but also really understand what kind of trainings we can provide to them moving forward, what kind of resources and toolkits that we can put together for them so that they have the information they need to share 988 as they're out there doing this great work as well. So Laura, that's all I have for SAMHSA's update for this particular episode. But again, thanks so much for having me. And it was a great to see you all today.
Thank you, Tiffany. Great to hear those updates and look forward to hearing what comes out of those convenings. And thank you for putting in the chat the link to the response systems TA. And at this point, I'm going to bring in Dr. Brian Sims of NASHBID for a NASHBID update.
Oh, thank you, Laura. And first and foremost, wonderful job you're doing in terms of hosting today's Crisis Jam. I wanted to bring up an update from NASHBID of some ongoing efforts that have been taking place. I kind of chuckled when Dr. Dole was talking about the past in terms of mental health treatment and otherwise. I recall the days, and this is in particular related to how the hospital systems were set up and the degree of, in this case, smoking that took place within the hospital settings. This topic and what I wanted to bring up today is an update of what NASHVIT has been doing in terms of efforts with smoking cessation across the country. In our discussions, it has been kind of a historical journey that hopefully is cycling back to what it used to be. There was a point in time where smoking within facilities was extensive, to the extent that many programs, wonderful programs that are currently in existence, had come into play to reduce those numbers significantly. Then we had something called COVID that came through, and the smoking cessation efforts seemed to dwindle in favor of addressing the obvious concerns that came up with COVID. So what we're trying to do is reverse that and bring it back to a level where it used to be, and it's for obvious reasons. And it has a significant tie-in to the current efforts through 988, because we already know that smoking amongst adults is much more common in terms of its association with mental health conditions than those that don't have mental health conditions. And if you look at even during the time of COVID, approximately about 3 years ago or so, 23% of the United States adults with any mental illness reported smoking cigarettes during the past month. And that accounted for roughly 40% of the total number of cigarettes that were being smoked at that time. So when you look at this, you look at the whys of it. Smoking, we already know, increases stress. We know that smoking increases depression. We know that the association between schizophrenia and smoking, that people with schizophrenia are 3 times more likely to smoke than people that excuse me, that do not have the diagnosis. So it's important for us to take a look at it, but not just in the adult population. As we look at what we're doing now in terms of reducing the smoking amongst our youth and young adults, we've replaced it with vaping, but it's also to show that vaping is not our safe zone. That the CDC data that we have that from a year ago is showing that roughly 2.5 million middle and high school students used e-cigarettes, and that 3.3% of middle school and 14.1% of high school students were actively using e-cigarettes. And why that's important is because there's growing evidence to show that the vaping is not safe and that it is more affiliated with increased levels of suicide amongst those particular age groups. So we have very good reason to keep our ongoing efforts. And I want to be very thankful, number one, to the Smoking Cessation Leadership Center out of the University of California, San Francisco, that we have been partnering with for a number of years now, and their efforts nationwide to bring up new efforts. So we're going to be seeing this progressing forward. And I just wanted to raise awareness that as we look in our own communities, we need to bolster those efforts. Lastly, before I hand it back to you, Laura, real quick, I did want to comment on the slide that you have up there right now. It's a new one. I absolutely love it. And what it's attempting to show is that all the involvement that we've seen from the various states has been tremendous. But we also are looking at those states that we would love to have more information. Now, looking at this list, there are some that we have in the background that we're targeting to bring up. And I also wanted to highlight the fact that the smoking cessation piece is also something we're discussing through the crisis jam for potentially an upcoming one. So look forward to it. And thank you again, Laura. And thank you to SAMHSA for the incredible work that they're doing. And back to you.
Well, thank you, Dr. Sims, and thank you and NASHVIT for the work that you all are doing. And would just again amplify Dr. Sims and that if you are represented in any of these states that don't have a photo in them, and again, you want to share your lens on the crisis continuum, please reach out to the email in the chat that Karen has previously dropped in. We want to make sure that we are covering diverse perspectives. And again, your state is unique, your perspective is unique, and we want to hear it. Next slide, please. So we are going to go for federal updates. And we have Sarah Corcoran from the Guide Consulting Group on. Sarah?
Thank you, Laura. So I'm going to provide a quick update about a resource that we have previously announced, but has a few new bills that are reflected in it, just in case anybody had missed that previous announcement. So we can go to the next slide, but you'll see on this first one is a link. So we have a federal bill tracker for bills that touch the crisis care continuum. One of the main kind of legs of the stool, or kind of across the continuum. So you'll see a screenshot of some of the bills that are reflected. We've got a column for House bills, a column for Senate bills, and we also note if there is a House or Senate companion for some of these summaries. So we can kind of click through the slide a little bit. So these are across the continuum bills that touch on multiple legs of the crisis care continuum or suicide prevention. We've also got mobile team response, as well as crisis receiving stabilization facility focused bills. And there should be perhaps one more. There we go. And then one on bills that have been introduced at the federal level this Congress that have that touch on the call center capacity as well. So we'll try to keep this as updated as possible as bills get introduced to this Congress, and we've had an influx of more recently introduced ones in the past few months, and the link again is at the bottom. So please feel free to use this resource, and we'll keep it updated with what date is the last date that we've updated this with new bills as we wait for more to be introduced and text to be released. But that's it for me.
All right. Well, thank you, Sarah. Lots to stay up on federally. Now I'm going to bring in Stephanie Hepburn to talk about a recent, I believe this is a new one, right? Not from the vault, Crisis Talk article.
Thanks, Laura. Yeah, so unfortunately, Trace Terrell could not be here. He's in college and had a last minute exam. So he can't join, which made me sad. But I am so happy to talk to you, Laura, about it. So he is a youth mental health advocate, and he spoke with me on the intersection of public health and storytelling. And one of his concerns is that with lived experience, it's such a powerful way to talk about mental health, but it's often, he feels, put to the side. And he also talks about, for him, it was a game changer in his own life to work as a volunteer at Youthline, which is a peer-to-peer support helpline at Lines for Life in Oregon. And he said it was so crucial not only to help people, but for himself. And he said, you know, that the exchange between a person reaching out to the line and the peer counselor, he called it life-changing. And this is one of his quotes. He said, "There's a vulnerability in storytelling and sharing the challenges you're facing. Having your story resonate with a peer and reflected back to you is incredibly powerful."
Yeah, Stephanie, that just reminds me of a recent conversation that happened this week around nothing about us without us.
Mm-hmm.
I don't know if that came up when in your discussion with Trace of how important it is to have, you know, buy-in and not just being talked at. You know, you were sort of getting at that. Did that come up at all?
Yeah, and I think, you know, he said a couple of things, that the perception of the struggles that youth face, and the lack of involvement, allowing them to be involved. He mentioned two potential barriers that he sees. One is this idea that the struggles that youth face are not significant or critical enough. And then the other is this idea that they are unable to advocate for themselves, just an underestimating of their abilities. And so he did highlight that. And I think with 988, I think what he wants to ensure is there's that constant pressure to involve youth at every step of the process.
Yeah, and I think that that's just so important as we think about the subnetworks and other ways that we're trying to help provide supports for communities. I see Dwight, you know, you all at Lines for Life kind of mentioned in the chat that you love Trace. I don't know if Dwight, you want to come off camera or come on camera off mute and just share some of the work I know that you all are doing around youth and peers.
Hi, everybody. Can you hear me?
Hi.
Yeah.
We can hear you.
So it's so great to hear. It makes me smile and makes me feel warm and fuzzy inside whenever whenever I hear about the amazing stuff that Trace is up to. He joined Youthline as a Youthline volunteer in our Central Oregon office and made impact from day one. We've been thrilled to team up with Trace in places like the Finance Committee, United States Senate Finance Committee, where he's advanced mental health in really important ways. Our Youthline team is, along with our partners at Teenline, we're really committed in LA. We're really committed to this youth voice being a really prominent part of what we do, and the value and insight of youth to youth connection and the impact that has for folks who are struggling. It's just remarkable. You know, I tell people, it's, if you have kids, you've seen this dynamic where the kids are in the back of the car when you're doing a carpool, and it's like you're not there. And if they were to say something about something they were struggling with, whether it was bullying or a relationship or otherwise, if you were to weigh in from the front seat of your car, your kids would immediately shut down. But if one of the other kids back there were to say, hey, you know, that's the kind of thing I talked to my mom about, it lands in a totally different way. That's kind of the critical insight of the Youthline that Trace and the other 150 kids who do it here in Oregon have been so vital in carrying.
Yeah, well, thank you for sharing that, Dwight. And again, thank you for being a part of the 988 Lifeline Network. And I just want to also tie this back to some of what we talked about earlier in the jam, right? The number one reviewed YouTube and in-person meeting of the jam was the youth guidelines, right? And so thinking about how we can ensure that there's a crisis continuum that is adjusted, as Shelby said, to fit the needs of youth, and not trying to impose an adult system on them. So I just encourage everyone to read the article. I'm sorry that Trace couldn't make it, but again, understand in college, you got exams, you have to study, you have things. Anything you want to leave us with, Stephanie?
You know, he said so many great things. He talked about workforce and not only that, the skills that he learned at Youthline helped him in his life. I mentioned the exchange that happens, but also how it's really learning these skills is also creating interest in mental health and creating interest in working in mental health, and how it's really by supporting kids, there's this multifold benefit that we need to examine.
Yeah, thank you, Stephanie. Again, you can go to talk.crisisnow.com to view that and other articles, but really good stuff there. Let's take a look at our next slide and what we have coming up. And so I timed this perfectly. I didn't even plan this, but again, Dr. Belina Shaw, who presented with Dr. Anita Everett earlier in the Crisis Jam. I forget what episode that is, but it's the #1 episode. She will be back along with Bethany Myers for crisis services in rural counties. Again, another population group that we know is over-indexed in terms of suicidal ideation. So again, wanting to make sure that we are having crisis system supports for individuals in rural counties. And then the week after that, so next slide, please. It is going to be crisis services for Indigenous people as a featured presentation with Kobe Coughlin, and I always get her name wrong, but apologies in advance. Again, another feature presentation that is going to be great, and a lot of work there to serve, again, another population that has been historically marginalized. So thank you all for joining us today. Look forward to seeing you next week, and hopefully you all don't eat too much candy. So thank you for watching. We'll see you next time. And a reminder, if you are not following the daylight savings change, then your time will look different. But again, appreciate you all for joining us. See you next week.